So thank you very much for this incredible opportunity. And the topic of my presentation today is the clinical impact of filling the gap at immediate implant sites in the aesthetic zone using a xenograft, especially collagen, to prevent aesthetic and biological complications. So everything should start with a minimally traumatic tooth extraction, with the preservation of the hard and soft tissues after this extraction. And of course, at this moment, the clinician has to define the best timing for implant placement. And we know there are different options, each one of those related to their specific lists of advantages and disadvantages. And immediate implant placement is one of those that has been considered to be a very reliable, predictable, and sound alternative. Let's take this patient as an example to set the tone of this kind of procedure. So my dear friend Augusto comes into the office with the chief complaint related to this colored teeth, related to the old accident, and also complain a little bit about his gummy mile appearance related to this altered passive eruption. And he has, as you can see, a beautiful, thick tissue biotype. But when we observe the CBCT of the patient, you can already observe that the mesial aspect of tooth number 11, so the right upper central incisor, is associated with an external root resorption that makes this tooth obviously hopeless. So as part of the treatment, we decided going for the extraction of that tooth. But because he was lucky enough to have a very good anatomy of the palatal and apical bone, please observe that the thickness of the bone is extremely rare to see, thick like that, and this beautiful tissue architecture. So he had everything we needed to do a very predictable outcome. So we did everything according to the book. So minimally invasive tooth extraction. We placed the implant according to the prosthetic demands of the case. So a little bit towards the palatal, narrow implant diameter, platform switch, moderate rough surface of the implant with the position of the neck about 4 millimeters down, the position of the future gingival margin. And of course, we delivered the provisional restoration, and we did the grafting procedure that I'm gonna cover in a moment. So after 4 years, this is the kind of outcome that I can see. And those images pretty much determine to me or define to me the essence of the aesthetics in perio-implantology in such a way that nobody in this virtual room or anywhere else can ever tell that Augusto has ever visited a dentist in his life. Because please observe that the quality of the restoration are so pristine, according to the adjacent pristine teeth, that it's almost impossible to tell that he has an implant-supported restoration. With this beautiful leveling of the soft tissues, also related to the crown lengthening we did at the moment. But the most important aspect here is to see the buccal bone is preserved, and you can appreciate that the soft tissues are covering the cervical region of the restoration. And that is, to me, my dear friends, the fingerprint of the excellence of this kind of work. So making them invisible. Of course, that the comparison show a beautiful kind of change in the perspective of the smile of the patient, but we can predictably achieve cases like that if we are faithful and we follow the 3 most important aspects that we define as the triad of the aesthetic perio-implantology. And they are prosthetically driven implant placement, the aesthetic tissue reconstruction related to the bone and the soft tissues, and of course, the prosthetic management. So it definitely works and in a predictable way. However, it's also true that some cases can be associated with aesthetic compromises or complications, ranging from volume loss to marginal recession. But it has been claimed that those problems are pretty much related to the presence of some risk indicators, such as the placement of the implant in a too buccally position, or the anatomical aspect has not been taken care of, like thin tissue biotype or maybe the buccal bone loss. However, I like to make here a philosophical remark to make us think a little bit. I don't think it's fair or just to ascribe those problems to the immediate implant placement itself. I mean, regardless of the timing of the implant placement, if you place your implant too buccally position, or if you don't graft hard and soft tissues, you're gonna fall in the same kind of problems. So it's not a matter of the timing of implant placement. In our understanding, again, is not being faithful to the triad of the aesthetic peri-implantology. And that is the most important aspect to be considered. Having said that, this is our menu. So different options, as I mentioned. But if I have the chance to take out the tooth in the front region and the upper jaw in my patients, for sure that philosophically, I'm gonna move to immediate implant placement as the first option if I can, or if I can't do that, I'm gonna do grafting to the socket in such a way to improve the quality of the bone and later on place my implant. There's nothing wrong doing things from the left, but the more you wait from the time of extraction, the more dramatic is going to be the kind of reconstruction that's going to be required to treat that case. So in our perspective, we prefer to do the internal socket compensation, meaning that at the time of the extraction, I can fill the gap from the inside, not from the outside, pretty much being able to graft the inner side to preserve what's there, as opposed to graft from the outside to reconstruct what you have lost already. So that is just philosophy, nothing wrong about one or other option. So for us, this is the kind of treatment that I'm going to follow: immediate implant placement or socket preservation. And this is not a random decision. There are specific guidelines that will lead me to immediate implant placement or socket preservation. So the path of the treatment is determined by some aspects. The first two are the most important ones that will really define the path of the treatment: immediate implant placement or socket preservation. Whereas the other two will not change the treatment choice, but rather will impact in the strategy to reconstruct the case as part of the treatment. So as a matter of fact, it's quite simple in our understanding. So basically, you have to see first the CBCT of the patient. And you can either have the bone there to place your implant according to the prosthetic needs, or you can see a situation that you can't see the bone good enough to place your implant. And of course, you have to also check the position of the gingival margin that can be in different levels. So for us, if I have the apical and palatal bone sufficient to place my implant in association with a tooth in which the gingival margin is more coronal, level, or no more apical than 3 millimeters from the adjacent tooth as a reference, in those situations, we're going to move for immediate implant placement. However, if you don't have the palatal bone and the apical bone, regardless of the position of the gingival margin, and or you have a very deep gingival recession, regardless of the anatomy of the residual bone, for us, that's a strategy to go for socket preservation. The other player here, it's probably the most polemic among us different groups of research and clinical perspectives. And the buccal bone defect, for us, will not interfere in the decision, but again, can interfere with the strategy of reconstruction. So we can either have like an intact socket, or you can have like minimal socket damage, such as a fenestration or a smaller dehiscence. On those cases, in our hands, what we're going to do is to fill the gap or the socket with the xenograft Bios collagen, because it's much easier to use, and the literature shows that it's very effective to counteract the contraction of the healing of the socket. However, if I have this very wide and deep recession or dehiscence, that means that the defect is very non-predictable. So in that situations, besides using the Bios collagen that we always use, we're going to add a collagen membrane between the soft tissues and the boundaries of the bone to separate the bone from the soft tissues, pretty much fulfilling the concept of the guided bone regeneration. And here, I'm very happy to show you this small video that Turgut and Geistlich has performed with our help, suggesting that this kind of treatment. So after the tooth extraction, we see that the bone, the buccal bone is not there. So we have to do the reconstruction using our membrane. But the implant was good enough to place the implant. So now after the implant is positioned, we create a pouch or an envelope-like flap in the anterior zone to make room for the placement of the BioGuide shape, which is an excellent material to be used. And of course, Bios collagen filling the gap. We cut off the excess, place our restoration, and very typically we'd also have positioned there a connective tissue graft in that area. So the final piece of this puzzle is actually the tissue phenotype. And most of the cases today, after so many years doing that, we almost 100% of the cases, we also use the connective tissue graft in the anterior zone to really improve the thickness of the soft tissues, boosting up this area, improving the aesthetics of those situations. And that seems to be everything we do. So when we have a dehiscence-like defect, we create a pouch and place our collagen membrane on the boundaries of the dehiscence defect. We're going to always put Bios collagen between the implant and the bone or the membrane, and most often we would also place a connective tissue graft in those areas. So having said that, now let's see some clinical cases to describe our strategy of treatment. So this is not a patient, my dear friend. This is a walking outdoor that if you do anything wrong, you're going to have the consequence. And it's unfair because if everything goes right, nobody's going to tell you you did a good dentist. So again, it's being invisible. But unfortunately for her, she had a fracture on tooth number 11. And luckily for her, the socket is intact and we have a good residual bone in the apical and palatal area and a very nice gingival architecture. So we do, as we described it before, I take out the tooth in a minimally invasive way, preserving the hard and soft tissues. And now is the moment to place our implant, as I just described it before, in the best three-dimensional positioning. The implant was so stable that we were allowed to place a provisional restoration on top of that implant, of course, taking all the considerations to the critical and subcritical contour of the subgingival area of that restoration, not to put pressure on the soft tissues that might lead to some aesthetical complications. When the prosthodontist here is polishing this area, this is the moment we come back into the field and we do the socket grafting with Bios collagen in that area. No membrane, because the volume of the bone was intact. And this is the occlusal view showing beautifully the implant well palatal to the area and the socket completely filled with our xenograft. Does it help? What does the literature tells us? And we know from a lot of information from the literature that whenever we use this kind of material, Bios collagen, within the gap or the socket, it will block or diminish or compensate the natural contraction of the socket that naturally takes place. So it's very effective to make bone to be there in such a way that will prevent the soft tissues to go in the apical direction. So that's a good alternative to be used. What does it happen if we, on the contrary, do nothing in terms of the filling this gap? We know what's going to happen. What's going to happen is that we're going to have a collapse from the bone that's going to resorb and the soft tissue that will move all the way back to reach the implant threads that can lead not only to some kind of recession, but also can lead to some kind of exposure of the implant that might lead, on the other hand, to peri-implantitis. So please do not forget to use the Bios collagen inside the gap at that moment. And of course, we also have to perform our soft tissue augmentation in terms of the placement of a connective tissue graft in that area. So on that regards, we create a pouch in the buccal area without lifting the papilla, and of course, harvest the connective tissue from the palate, and we place it under the flap, under margins, and suture in a simple way. This is the final outcome of the patient immediately after the case is finished. And we all know the benefits of the soft tissue grafting related to the improvement of the thickness and the quality of the soft tissues that can not only bring aesthetics, but also provides a better environment for the prosthodontist to work in a better scenario, preventing as well other situations. But not that only. There are several publications showing that this is predictable, preventing complication in terms of aesthetics. And today we can also say that the thicker tissue biotype will also help to preserve the bone that is below this area. So this is our patient finished 6 months later. And this is the moment we take out the provisional restoration to do the implant transfer to do the prosthesis of the patient. And please observe the cervical region with a lot of volume of the soft tissues. So the impression taken is made, the abutment is positioned, and of course, here is the patient 1 year later, in which we have reconstituted here a beautiful bone in the buccal area, and we have a perfect leveling of the soft tissues. This is stable, for sure. This is the same patient 7 years down the line. And please observe the symmetry of the gingival margin, and again, the occlusal view, because this is the fingerprint of the aesthetics. Whenever you look this occlusal view and you see the cervical region of the restoration being covered by the soft tissues, this represents the excellence of the reconstruction. And of course, the bone is there, and we can see a very stable situation through time. But that's not the average case we see every day. This patient here is much more resembling what we see in an everyday practice. Again, a very dramatic situation related to tooth number 21 that is going to be lost. And you can see in this x-ray that there is no buccal bone whatsoever, but the soft tissues are okay. And we have the palatal bone our disposal. So we're gonna take out the tooth, we're gonna clean the area in a very good way. We can see that there's no buccal bone there, meaning that we have to place a membrane as part of our strategy. The implant is then positioned in a very good aspect, and the provisional restoration is also delivered because of the good primary stability. And while the prosthodontist is performing the polishing, we come again and do our tunneling procedure as part of the strategy to reconstruct, and we place the membrane, the collagen membrane, between the flap on top of the boundaries of the dehiscence, and below that area, we place our xenograft, Bios collagen in that area. This is the occlusal view showing the reconstruction. And in this case, we haven't used the connective tissue because we felt it was good enough. But please observe the typical view of the x-ray when we have those situations in which we have this excess of bone in the buccal area. But this is also the typical view through the 6 months period after the treatment, in which we come from 0 bone to this excess of bone immediately after. Then the bone seems to collapse, the bios seems to collapse to reach its final real positioning. And is it stable? Yes. And is it reliable? Yes. In our retrospective analysis, doing cases over 10 years like that, we noticed that when we have situations like that with damaged sockets, we are able to reconstruct from 0 to the average of at least 2.5 millimeters to 3 millimeters of new bone. So this is the patient again in the occlusal view, in which we take out the crown, we make the implant transfer, we take out some particles of the bios that are there, not a problem. The adjacent tooth is prepped and the lead communication is performed. And this is the delivery of the abutment and the two crowns, implant supported and tooth supported. It's a little bit hurt, of course, but this is the patient 1 year down the line, in which you can see a beautiful stabilization of the smile of the patient. And this is the same patient 7 years later. And as you can see here, the buccal bone is completely stable, supporting the soft tissues. The interproximal bone are there, and we have this beautiful leveling of the soft tissues here. But my dear friends, do not trust frontal pictures. The excellence of the reconstruction is always observed on the occlusal view. And this case here, although we didn't have any recession, we had this loss of the volume through time. And this soft tissue will never recede apical because there's a lot of bone there, but we have lost the buccal prominency in this area because we haven't not added the connective tissue graft. So please observe again that in the adjacent tooth, the soft tissue is covering the cervical region, meaning that the gingiva comes first. In the implant, it's like a butt joint situation, and that is not the essence of our ideal situation. I know that you may have heard before that soft tissue is the issue, but bone sets the tone. For us, it's the opposite. Bone sets the tone, but soft tissue is the issue, and aesthetics is imperative in our cases. So to finish my presentation in my last 3 minutes, I like to show the full course that we like to use. So a patient comes in the office with the upper right central incisor fractured, but associated with a gingival recession on both central incisors. You can see that we have no buccal bone in that area, and we do exactly what we mentioned. Take the tooth in a traumatic way, place the implant accordingly, and we do the aesthetic tissue reconstruction. Soft tissue, membrane because we had a big deficiency, and the bios collagen in that area. And of course, the provisional restoration being positioned, and all the tissue is being brought in the occlusal direction. And this is it, our outcome at 6 months this moment, showing this beautiful leveling of the soft tissue of both right and left central incisor, the reconstruction of the bone, and at that moment, again, the fingerprint of the aesthetic tissue reconstruction, meaning the volume of the soft tissue and the perfect symmetry on the balcony of both central incisors, tooth and implant supported. So that is the resume of this situation, placing the implant accordingly after a tooth flapless extraction. The aesthetic tissue reconstruction, all cases, bone, bios collagen, several times the membrane because of the defect and the connective tissue graft, the excellence in the prosthetic rehabilitation, the perfect volume, and that is being faithful to the 3 pillars of the aesthetic perio implantology. With that, I thank you very much for your attention.
Robert, thank you so much for this beautiful presentation, beautiful surgery, beautiful restorations, amazing. There's plenty of questions. So one related to the connective tissue graft. What type of connective tissue graft do you like to use? Do you take like a de-epithelialized, like a free gingival graft de-epithelialized, or you take more like it looked like more like a classical type of connective tissue graft? And if yes, what do you think the differences, advantages, disadvantages? How do you see this question?
Okay, it's a great question, Istvan. As a matter of fact, we love to use the connective tissue graft taken out in the traditional way. And because now, more recently, a lot of people has been discussing the benefit of taking the free gingival graft and de-epithelializing it outside the mouth, it seems that there's no room anymore for the connective tissue graft. And that's not what we see in our practice. We have great clinical outcomes using the connective tissue graft, but it's true that when we have a more fatty tissue and glandular tissue in the palatal area, the quality of the soft tissue may not be so good. And because of that, we have the tendency to lose a little bit of the benefit of adding that connective tissue. So whenever we feel with the first incision that we're gonna act in a more soft tissue, we might just go ahead and take out the free gingival graft and de-epithelialize it outside the mouth in such a way that we have like the lamina propria, a thicker tissue and more stable tissue to be used. Other than that, if we don't see this fatty tissue, I don't think there's a difference at all, and we have been doing that over a decade and with outstanding outcomes as well.
Do you take it from the regular, like first molar and that region, like premolars, or do you go behind, or maybe the anterior maxilla, or how do you evaluate the thickness before?
Yeah, we know that the more posterior region, we have a kind of thicker lamina propria. So basically, in the cases that I treat, I have the tendency to take the connective tissue from the premolar towards the molar region. Of course, that depending on the dimension of that area.
Yeah.
But very frequent, I also take from the premolar region.
It's a little bit more dense back there, right?
Yeah, a little bit, yeah.
That's what we see too. Do you ever use the tuberosity for anything?
Oh yes, for sure. Sometimes we use the tuberosity tissue, which is very easy to be used because it's very firm and it doesn't break down as the connective tissue sometimes are a bit loosey. However, some cases that we have done the same procedure with the connective tissue taken from the tuberosity, we have seen in a limited number of cases an overgrowth of the tissue through time.
That's why I'm asking.
Yeah, so I have some regards on that area. I'm going to use it depending on the situation, but I prefer much better taking the connective tissue from the most palatal area or most distal area from the palate. So
today you would say again, like today is 100%, or how much percentage you would put the connective tissue graft today for an immediate?
100%.
100%.
In the cure zone, 100% for sure.
Do you ever see anything changes on the phenotype, like the stippling of the tissue and the overlying tissue? I know that you put it below, but after that, and not only the tuberosity, do you see any little color change, little bit of the stippling blunts off, or not exactly? When you look at, not in a photography, but like, you look at it with your own eyes. Okay. Do you see any change on that?
That depends on the amount of keratinized tissue and the thickness of the tissue we have at the moment of the treatment. So in my understanding, when we have like a thicker tissue in height and width, we see less of this change. But if I have a very thin tissue biotype, because of the positioning of the connective tissue graft, we can see an increase in the dimensions of the keratinized tissue, and we see a improvement in the quality of the soft tissue. I haven't noticed anything like in the stippling of the soft tissue, but for sure the quality of the soft tissue seems to be improved in those cases.
Very good. Now, what if you have a recession, like extracting the tooth, but that was like a 2-3 millimeter recession?
So again, keep going.
Let's say you have a defective socket.
Okay.
And you have a recession.
Okay. How deep is the recession?
Very ideal to place an implant immediately. Okay.
How deep is the recession?
I'm telling you, like 2-3 millimeters.
for sure, in a predictable basis, immediate implant placement, and associated with aesthetic tissue reconstruction. In that case, always associated with the connective tissue graft, because we are very predictable to cover 2-3 millimeters of gingival recession.
So you do tunneling and covering?
Yes, tunneling, yes.
Tunneling and coronal positioning it.
Yeah, yeah, connective tissue graft, the BioGuide shape because of the dimensions of the dehiscence, and the xenograft. And then we bring everything in the coronal direction. We have been doing that for a long time, and it's incredible the success in that cases. Of course, Istvan, that one case is in 100 or a limited number of cases, something can go wrong, but that can happen to any kind of implant placement. But I think it's a very effective approach.
Now, let's stay with the compromised socket. You put in a 100% biomaterial, which is very well documented for intact sockets, right? But do you think you put a membrane, you put like the biomaterial, do you get what we see? Is it real bone? What we see, what we get, or would you ever maybe mix it with a little bit of autograft if you would get it in your hand, or do you trust that you will put that in and you get 100% bone?
In the socket, within the boundaries of the socket, I don't use anything rather than the biomaterial, because inside the boundaries of the socket, it's a very closed and favorable area to be regenerated by the cells from the adjacent regions, which will makes its way around the particles of the material. And think with me, Istvan, if that was not the truth, we would know that already, because everybody performs socket preservation using this kind of material, and we don't lose those implants more often that we lose implants placed in pristine situations with 100% bone. So that is a clinical indication, regardless of the tremendous amount of literature in the animal showing that that's bone surrounded or surrounding the particles of the bone, that's clinically relevant and reliable in my perspective.
Now, how do you see that, there are techniques like when they extract a tooth, there's a fully compromised socket and there is an implant placed and sometimes an autogenous bone block, like a tuberosity graft and things like that. Do you ever try that? What do you think of it?
Yes, our group, especially Paulo, that you know him so well, he has done many cases like that, and it's pretty much very predictable. The IDR technique from our friend Rosa, that you know him so well as well, it works perfectly, because the essence of the treatment that he proposes is exactly the same. So implant position in the perfect direction, the aesthetic tissue reconstruction with a different material, and the provisional restoration doing a good way. The thing is that sometimes, in our opinion, we don't have the anatomy of the tuberosity, and I know that he might disagree with me on that, but that's okay. Sometimes we don't see that in a good way, but if you have it, you can do it in a perfect way without a problem, and it's going to work beautifully.
Thank you so much for this beautiful presentation. Okay.
Thank you. It's my pleasure.
Take care. Bye-bye.